All right, good morning, everyone. Thank you so much to Greta and Vinny who invited us to speak this morning and for everyone joining us. It's always amazing to spend time together in this with all of you who are doing amazing things in UW and in Madison. We're excited to bring you this discussion on integrative approaches to long COVID. This morning, we'll be summarizing what is already known about long COVID and more so appraising the evidence-informed therapies for long COVID.
All right, so we're going to start with a case. And this is a patient that I saw in clinic. So she was a 51-year-old female, relatively healthy, has a history of eczema and depression, who presented with 1 year of fatigue, palpitations, and decreased tolerance to exercise. She was very healthy prior to COVID and got it in summer 2021-ish. And now has been having a lot of difficulty at work, lots of brain fog that has been making it hard to focus and get things done. And then she also has problems doing things at home. However, the thing that actually bothered her the most was that she was having a really hard time walking her dog. It was very important to her to be able to get out every day and take her dog out for a walk, go to the dog park. But every single time she tried to do that, she would start getting palpitations, she would be short of breath, and just really having a hard time continuing the walk to the point that she had to essentially stop walking her dog. And so she was looking for help and how to improve that. So her COVID infection itself, she had some cough and shortness of breath. She also had fatigue. Those were really her main symptoms. She didn't really have any of that, the cardiac symptoms initially. She did end up presenting to urgent care, and then they transferred her to the ED because she had an elevated D-dimer. But imaging was, it said CTPE was normal. It showed COVID pneumonia, but there was no PE there, and she was discharged home. She didn't need any oxygen. She was eventually treated with hydroxychloroquine, vitamin D, vitamin C, and zinc by a provider from Florida, and started feeling better after that. Her symptoms lasted about 3 weeks, and the fatigue was so bad that she was describing being really unable to get off the couch during that time. So since then, since she's recovered from the acute infection, she's had normal chest x-rays, she's had PFTs that have been totally normal. She had mostly normal labs, however, her D-dimer did remain elevated. And then there was a cardiac stress test that was pending and just hadn't been done yet. So everything so far had been normal. It was just, she still is feeling not great. So what is long COVID? Interestingly enough, it actually wasn't defined until October of 2021. So that's quite a ways after. I feel like there's just been this huge time warp, and it feels like COVID has been here forever, but it hasn't, and it's only been a couple of months since we've actually been able to say what this is. So they met up and did this consensus that was in October that essentially is if someone has had COVID in the last 3 months and their symptoms are lasting for 2 months, the symptoms can be pretty much anything, but the most common ones are fatigue, shortness of breath, cognitive dysfunction, that brain fog that people have, and chest pain. And then also, most importantly, that it's not explained by any other diagnosis. So still doing the workup for other things like lungs and heart to make sure that nothing else is going on, vitamin deficiencies. So as long as it's not explained by another diagnosis, that it can be called long COVID. Prior to this, there were a ton of different names for this conglomeration of symptoms, ranging from like, we'll actually get into this on a later slide, but post-acute COVID, long haulers, persistent COVID, just all kinds of different things, which actually made it really difficult to study, because if we don't have a specific name for something, it's hard to say you're actually studying it. So that kind of comes into play as we get further into this discussion. Who gets COVID or long COVID? That is also something that we don't know very much. So there was a systematic review that was done in Brazil, and they looked to see what the frequency was of long COVID. 4.7 to 80% of people who have had COVID will get long COVID. That is a huge range, which essentially means we have no idea what the frequency is. Again, part of that is because this study was actually published before we had a name for it. So again, it's just really been difficult to nail these things down without having that actual diagnosis. And then it talked about the different frequency of the actual symptoms in long COVID. And those, most people have chest pain, a lot of people have fatigue, shortness of breath is another big one, cough is big, and then even up to 57% of people can have the brain fog too. Other ones that were noted, but not quite at the like greater than 50% were myalgia, sleep disorders, functional impairments. So those are all things that can happen too. Risk factors for people developing COVID, only 10, oh, yes. So only 10 studies actually looked to see what the risk factors were out of the 25 that they found in this review. And they never listed the like how much of a risk factor it was. So again, take all of this with a slight grain of salt. But advanced age, female sex, having multiple comorbidities, and then having severe COVID is another one that increased your risk, though it didn't necessarily mean that you would get it. And then having hospital admission and oxygen supplementation, that kind of goes along with that severe clinical status as well. But all of those seemed to increase the risk a little bit. Then none of the studies that they found, so out of the 25 studies that they found about this, none of them mentioned any information about the duration that long COVID can have. So we have no idea how long it will last. We don't know the frequency, and we know some of the symptom frequency, but again, that was a very large range too. And we also don't know what causes it. So a lot of these things are unknown because they haven't been able to be studied because this is so new. There was one article that kind of went through and said these are our hypotheses, but we don't actually have any data to say that yes, this is what's causing it, which makes it even harder to figure these things out. But endothelial damage is one hypothesis. Autonomic dysfunction is another. Lots of microscopic or microvascular thrombi is something that we think about too. And then the direct viral mediated responses. So we know that COVID enters through the ACE2 receptor, and we do see downregulation with the virus. So is that what's causing it? Is it the huge inflammatory response that happens when people get COVID? Is it oxidative stress from the virus and that inflammatory response? We don't really know, but these are things that could potentially be contributing.
So after appraising a lot of different studies, we realized that we do have to ask the important question of whether the severity of COVID disease is related to the development of long COVID. And the following study illustrates why so few studies ultimately met our inclusion criteria. So this was a randomized multi-center observational study in Madrid of individuals who were hospitalized with COVID between March 1st and March 31st, 2020. So pretty early in the pandemic. Individuals were randomized from 3 public hospitals in Madrid and were scheduled for a telephonic interview. So this was early in the pandemic with the original COVID Wuhan strain. And the telephone interview was took place 12 months after the initial infection. So 12 months after the initial infection, these individuals were asked about the presence of respiratory symptoms. So fatigue, dyspnea, chest pain, cough. And ultimately, they found some very interesting information that there was no association with being an active smoker, with obesity, or even experiencing cough and onset with the development of long COVID respiratory symptoms. They also found that 12 months later, the prevalence of long-term cough was still 2.5% in those who survived hospitalization for COVID-19, showing that a lot of these long COVID symptoms last well over a year. And they found that ultimately, this is the most important part, that the severity of hospital stay was not associated with long-term cough. So interesting, the presence of symptoms is not related to the severity of illness, suggesting that the pathophysiology of long COVID is unique from that of acute COVID infection.
But we can kind of, based on our patient's story, we can say she likely has long COVID. She still needs to get that stress test to rule out that, but we can probably say, based on the definition of what long COVID is, she likely has this. So then our question became, well, what can we do to help? Because right now, we don't have a lot of options. So in order to answer this question, we did our own systematic review. This was our search criteria. So as you can see, there are many different names for post-COVID. I don't know if you can see my mouse here, but like post-acute COVID syndrome, chronic COVID, post-COVID, long haul COVID, just many, many, many different things that people could call this one entity. And then we tried to think of every single thing that could possibly be integrative. And I'm sure we've missed a couple, but these are the things that we searched for in order to kind of find things that could be helpful. And then we narrowed it down to English only articles. And then we said, you know, hopefully we'd be able to find enough information that we don't need like case reports, but we also didn't want letters, editorials, or comments in our search. This search was run on February 12th of 2022. So we went then and looked through all of the different abstracts and titles and essentially took them out if we didn't think that they were useful or they didn't fit our criteria, which was essentially it had to be about long COVID using the definition. It had to be including some sort of integrative modality. And then it also had to have some form of data. So there were a lot of articles that were about hypotheses and just people kind of talking about what they think might be going on, but with no data. So those ones were removed as well. And then we both looked to make sure that, so there were 2 of us that went through this. And then of the ones that were left, or that after we looked through the abstracts and titles, we then went through the article fully to make sure that we were able to get all of the data from it. And then got rid of ones that also still didn't fit. So running that search, we got 198 articles, 5 of which were excluded based on being abstract only, so didn't really have any information in those. And then 139 articles were excluded based on the review of the title and abstract, which left us with 56 articles that we reviewed, and then 3 that we found after doing a couple extra searches through the articles themselves, their reference lists. So after going through those 56 articles, 46 of them were then excluded based on actually going through the article. And that left us with 13 that we'll be going through today. We're actually going to be going through a couple more than 13 just because there were some that were helpful to at least talk about, but 13 is what we got at least. So that brings us to our first section, which is nutrition. And not a lot of information here. So there was one study that looked at long-term evolution of malnutrition and muscle loss after COVID. And they were thinking that this is probably a major component of long COVID. So patients in the study were recruited from hospital admissions in a hospital in France between March 2020 and April 2020. So brand new COVID at that time. 288 patients were initially included, 150 of which had no further sequela at 16 months. So they didn't really follow, at 6 months. So they didn't really follow those ones and look into what was going on with those. They looked at the 138 patients that ended up having the long-term symptoms. So of those, then they were able to get a hold of 119 at 30 days and 6 months, and in order to kind of evaluate how they are doing. I do want to point out that at 6 months, there is a, can you see my pointer actually?
Yes, we can see it.
You can. Okay, sorry. I figured I should have figured that out beforehand. Anyways, so there is an improvement of malnutrition over time. So if you look here, so at discharge, there were a pretty significant portion of patients of those 119 that were malnourished at discharge. But at 6 months, a significant amount actually improved. However, there are still about 36% that are at least moderately to severely malnourished. So it does improve over time, but it takes a long time. I mean, if you look at the 30-day mark to the 60 or to the 6-month mark, that's quite a bit of time that has to pass. So patients between these times were treated with an unknown amount of dietary counseling. They were also treated with an unknown and unclear amount of nutritional supplementation and physical therapy. But like I said, they didn't actually talk about exactly what they nutritionally supplemented them with. They didn't talk about the dietary guidance that they gave these patients. Or the specific physical therapy recommendations that were given. So things happened, not entirely sure what things. So what I wanted to point out at this study was that, so they said they had 217 patients who recovered their symptoms by 6 months. Those people had some malnutrition. About 50% of them had malnutrition. The 53 patients that were still not improved at 6 months, 82% of them had malnutrition at discharge. So there is likely some component of malnutrition that's contributing to long COVID. However, we don't know exactly how much, and we also don't know what things we can do to improve it. Yeah. So, as I said, yes, it probably contributes, unsure the degree of that, and no clear methods to improve the malnutrition, though whatever they did worked for a lot of people, because there was improvement, but again, we don't know exactly what it was. And I'm sure reaching out to those that did the study would probably be able to actually tell you, but it just wasn't written in it.
Okay, so our second section is supplements. And going through several sources, most of them would agree that the aim of supplementation would be to support the body with micronutrients to ultimately address oxidative stress, which promotes early recovery, reduce post-viral fatigue, as we're talking about. And this is in order to optimize both the nutritional factors and immunological status and offer future resistance in often poorly nourished patients. So interestingly enough, we found two studies about that looked into isolated loss of smell, which is one symptom of COVID that can have a significant negative impact on quality of life. So we'll be going through two studies that assess therapies that include supplementation for the management and rapid improvement in this isolated loss of smell. So the first study is randomized clinical trial olfactory dysfunction after COVID-19, looking at olfactory rehab therapy versus intervention treatment with two supplements and olfactory rehab. So this was an Italian ENT team who enrolled 12 patients, a very small subject number in this study to evaluate patients with confirmed COVID-19 with post-infection olfactory impairment that persisted beyond 90 days. So that was the inclusion criteria, was beyond 90 days. 7 of those 12 were placed in the rehab plus supplement category, and 5 were controls with just olfactory rehab. And as you can see in this slide, at that 90-day period, they did evaluate binasal endoscopy to rule out any other etiologies for the isolated loss of smell. They randomized patients and then used sniff tests, sniff stick tests to assess the smell. And then we discussed the randomization, and then there was 30 days of treatment. So either 2 times a day rehab alone, or 2 times a week rehab plus daily supplementation of PEA and luteolin. So PEA looks like is a endocannabinoid-like lipid mediator suggested to have analgesic and anti-inflammatory properties. And then luteolin is a flavonoid used in Chinese medicine, also said to have antioxidant, anti-inflammatory, and neuroprotective properties. Ultimately, the study showed that patients receiving olfactory rehab plus supplementation for 30 days had greater improvement in their symptoms with a P of 0.01. The second study here is a bit of a different approach, and this was using essentially consensus guidelines and evidence-based recommendations determined by an expert panel. So a team from the UK performed a literature review prior to this study. So the evidence was summarized for the expert panelists. The reviews were largely based on systematic reviews. And the expert panel consisted of 15 members of the ENT UK task force. So their inclusion criteria was post-viral olfactory loss greater than 2 weeks. And this was based on the premise that most isolated loss of smell resolves within 2 weeks. And then at least 10% of cases will last beyond that 4 to 6 week period. So they found that after 2 weeks would be the best time for the inclusion criteria for the systematic reviews. And after doing the review, they brought in, if you can go back, sorry, they brought in the expert panel, and the expert panel used a RAND UCLA methodology, which is a modified communication method. So the group of experts used a multi-step process to reach consensus over a series of questions based on clinical symptoms. And they actually had to go through 2 cycles of this process. And the process ranked and classified appropriateness of different investigations and treatments. There had to be a 70% rate of agreement between all the panelists for them to ultimately recommend a treatment, make a treatment optional, or not recommend a treatment. And that had to be at a 70% consensus. So the next slide will show the conclusions from this. So the ENT panel decided that with isolated loss of smell less than 3 months, it could be managed by a general practitioner. Greater than 3 months, they recommend an ENT referral. The recommended treatments were intranasal corticosteroids and olfactory training if symptoms persisted beyond 2 weeks. Omega-3 supplements were optional, which meant that they could be undertaken or prescribed based on discussion with individual patient based on likely risks or benefits. And then not recommended, which there was a long list of supplements that would obviously entail that they should not be undertaken or prescribed based on current evidence. The one interesting caveat was vitamin A drops. There was a disagreement on that use, so the consensus was not reached at 70% for that. So it went into its own category of disagreement on the use. So now we're jumping into vitamin D, which I'm sure everyone's very interested about, as this has been recommended at least for COVID recovery and even possibly long COVID therapy. So this investigated the relationship between vitamin D and persistent symptoms. This was an observational study on the long-term sequelae of COVID with persistent symptoms, and the relationship between vitamin D levels and fatigue and reduced exercise tolerance. So this study was conducted at the post-COVID-19 clinic in Dublin, Ireland, between June and September 2020. So again, pretty early in the pandemic. 149 participants were recruited for this observational study. And overall, the median time from infection was about 79 days. So we were looking at about 11 weeks from PCR confirmed diagnosis. And they gathered data on vitamin D levels after infection, or 11 weeks post-infection, and then performed the Chalder fatigue scale, which we'll be seeing through the supplement studies as a pretty standard study or scale for fatigue. So this this looks at 11 questions that in relation to physical and psychological fatigue. And they looked at in reference to the past month of their symptoms and pre-COVID baseline. So again, there can be some observational bias, comparing 11 weeks from COVID infection to what their pre-COVID baseline was. But that is a pretty accepted system between these studies. And then using the Likert scale, which measures responses and gives each response a 0, 1, or 2, or 3 category to then create a bimodal distribution for the answers. And then they also did a 6-minute walk test, which is pretty self-explanatory, and then a modified Berg scale, which also looks at fatigue. So here we see, this was the interesting thing, that really the only significant relationship was that between age and the 6-minute walking test, chronic fatigue symptoms, and female sex, and then again, the fatigue scale based on the Berg test and the female gender. But there is absolutely no correlation between vitamin D levels and COVID infection. So the difference ultimately was non-significant. Low levels did not predict the severity of the disease during hospitalization, and then also did not associate with persistent symptoms. So the results do suggest, surprisingly, that persistent fatigue and decreased exercise tolerance is independent of vitamin D levels. The only caveat for this study is that the process of recruitment of subjects was unclear. I don't know, it's hard to say if maybe because the subjects were still at the post-COVID clinic, if there was some sort of bias of recruitment because they were already attending that clinic. And we didn't really have any information on how many of the participants were supplementing vitamin D, and if there was any significance with those groups either, of supplementation versus not supplementing. So we're going to jump into a few, I would say, sort of multivitamin supplements. So this is a portal. We'll look into what is in the formula for this supplement. This is an observational study, again, looking at the benefit of this supplement supporting immune function, and then ultimately on chronic fatigue. So this study looked at 201 patients from Italy who had contracted COVID-19 and had overcome the acute phase, but still reported fatigue. That acute phase was defined as a PCR negative, or a COVID PCR negative test, but the subjects could have been recruited with a very or it could have been a very acute infection or a subacute infection. They didn't have a cutoff for when the subjects were recruited for this study. So a portal, as you can see, has a lot of different vitamins, minerals, supplements within it. Vitamin PP is niacin, and vitamin H is biotin, and then everything else is, I would say, pretty self-explanatory. You can kind of glance at that, that some of the doses are pretty low. L-arginine is a pretty therapeutic dose, but maybe some of the others are on the lower side. So the methods for this study included, again, an observational study, recruiting 201 patients, given 1 sachet of this Aportal daily for 28 consecutive days. And they assessed the patients with questionnaires at the beginning of the study, at 14 days, and at 28 days. The questionnaire that was used was the EQ5D questionnaire. That looks at mobility, self-care, daily activities, pain and discomfort, and anxiety, depression. And then they also looked at the FACET fatigue questionnaire, which consists of 13 items, originally used for cancer patients, but it's been validated for other chronic diseases. So they decided to use it again for long COVID symptoms. And then also, thirdly, assessing mental fatigue with the modified Chalder questionnaire, which modified meaning they just used the last 6 questions. The exclusion criteria for this study was that patients that were admitted to the ICU or had several, so 3 or more chronic diseases were excluded from the study. So they generally tried to recruit healthier patients or those who had milder COVID disease. So they found that they didn't give us p-values, they just gave percentage values. So at least they looked at least 1 unit improvement, 3 unit improvement, or 10 unit improvement. So I just outlined the 10 unit improvement since that's the most dramatic improvement we can look into. And they found that within the first 2 weeks, there was a 32% improvement in symptoms, and over 28 days of supplementation, they found there was a 50% improvement. Again, no p-values were given within the body of the study. What they did look into and give a p-value for, which is interesting, is comparing the gender differences. So based on recent literature, there is a different incidence of chronic fatigue in females and males. And as Megan mentioned in the introduction, the female gender is a risk factor for long COVID. So they wanted to extrapolate the findings by gender. And what they found was that the differences between genders were always statistically significant, at least within the realms of this study, and the improvement in fatigue symptoms. The limitations on this study was that this was an open label trial and there was no control. The next study looks at a multivitamin. This study also is from Italy, recruiting 40 subjects who recovered from COVID-19 and continued to complain of fatigue. 20 were placed in the food supplement multivitamin group, and 20 were placed in the control group. The formula included, as you can see, all of these vitamins, minerals, supplements, and again, I would say mostly on the lower side of dosing for most of them. They the 20 patients were given 1 pill a day for 15 days, and then symptoms were assessed through the AD-ACL short form, looking at energy, tiredness, tension, calmness. And again, this was scored on 1 to 4, and then ultimately to create a more bimodal distribution of the responses and of data. So the results for the study was there was a self-reported energy level that doubled after 15 days, and tiredness and tension actually halved within this study. I also did not see any p-values for this study, and all the other information I left out was because it was not given. So there was no information on how those 40 subjects were recruited, no information on why that specific supplement was chosen. And then I did not also see whether the control group received a placebo pill or if they just received a questionnaire to fill out. Now we'll be jumping into 2 studies on probiotics. Again, the study is from Italy, and this study recruited 58 patients. This study is from the Division of Infectious Disease in Rome, Italy, and included only hospitalized patients from March 1st to April 30th, 2020, so very early in the pandemic again. All enrolled subjects were acutely or severely ill at the admission to the ER. And interestingly enough, this study was done while the patients were still in the hospital. So 24 patients received oral bacteriotherapy during the entire hospitalization, and the median amount of days was 23, but the range was 19 to 38 days in the hospital. And then 34 individuals were not supplemented during the hospitalization. Median days was 21, and the range was 18 to 26. And all of them obviously received standard of care therapy with antivirals, antibiotics for their symptoms while they were hospitalized. So we took these patients, and 6 months after discharge, they were given a questionnaire, the fatigue assessment scale, a 10-item questionnaire to assess their perceived fatigue. Okay, and the formula for this probiotic, as you can see, is outlined here, and the dose was 2,400 billion, so about 2.4 trillion bacteria per day, divided 3 times into 3 doses. So next slide shows that the results do suggest that in COVID-19, the administration of probiotics may prevent the development of chronic fatigue. They found that there was a significantly higher proportion of subjects positive for fatigue in the probiotic negative group with a P of less than 0.01. They also looked into any sort of clinical characteristics or therapeutic regimens that could have been statistically significantly different, but they found that overall the characteristics of the patients and also their therapies were not statistically significant during their hospitalizations. And then they also did a post hoc power analysis relative to all the endpoints. And they showed that for all considered variables, the power was more than 50%, which with most of the endpoints actually showing greater than 90% retained power. So this study did actually consider power within. The only stated weakness of this study was that it was still an observational study, but the administration of probiotics may be helpful to prevent fatigue.
Sorry, I don't know what happened. Interesting. When you get a phone call on your phone, it takes down your entire presentation.
Oh, yeah.
Here's the next slide.
That didn't happen to me either. I don't know how to mute calls on my computer. Thank you, Megan.
Yeah.
So the last study that we'll be looking into within the supplement category is also on probiotics. And this was a randomized, multi-center, double-blind, placebo-controlled trial that was conducted in India between 3 centers in 2021. In May 2021. And this actually the study recruited 200 patients that had COVID-19 at any time in the past. So again, we're looking at about a year period, March 2020 to May 2021. So anytime within that year. And patients were recruited from the outpatient department. And they needed to be at least 3 weeks post-infection defined as a COVID negative test. The 200 subjects were divided into a control group, which included a sugar pill, essentially, and then 100 patients that received the probiotic supplementation. The inclusion criteria was males, non-pregnant, non-lactating females between 18 to 75. Exclusion criteria, anyone with severe to critical health conditions, which included ICU hospitalization. as you can see the formula here, I did grab this from Amazon. That was the only place I could find these two bottles, and they were side to side already in a picture. So there it is. The Immunoseb was an enzyme complex dosed at 500 milligrams, 4 capsules a day, BID. So about 4,000 milligrams of that complex, and then the Probiotics B probiotic complex dosed at 5 billion units, 2 capsules daily, so about 10 billion CFUs, and the placebo was maltodextrin. The primary endpoint were set to study the efficacy of outcomes to improve physical fatigue using the Chalder Fatigue Scale, and then also improvement in mental fatigue on that scale as well on day 14. So 14 days of supplementation. And the baseline showed that the average fatigue in the control and testing arm, so along those 200 patients, were very comparable at day 0, but they found that the average fatigue obviously improved between the test for the test arm. The subjects in the test arm showed significantly greater reduction in total fatigue when compared to the control arm with a P of less than 0.001. And this was again comparing day 0 to day 14. So if we look at that graph here, outlining how each question ranked between the control and test arm groups. So we see for day 14, the bottom there, which is the test arm, obviously is much significantly reduced compared to the control arm.
All right, so that brings us to our next set of studies. So body work. We were hoping to include physical activity, manipulation therapies, massage, healing touch, anything that involved touching the body or doing things with the body. There were no studies. So none that looked at anything beyond beyond acute COVID, or that measured how these modalities could help with long COVID. So a lot of area for future study for those who are interested in doing something like that. So then the question becomes, well, what do we already know in order to help these patients? Chronic fatigue syndrome is something that is fairly similar in symptomatology to long COVID, in that people are very fatigued and not able to do the things that they used to, lots of brain fog, things like that. There was a trial a couple years ago, the PACE trial, which was a randomized controlled trial that looked at what things could be helpful for chronic fatigue. And specifically, it was CBT, graded exercise therapy, and they did one other that I can't remember off the top of my head because it wasn't relevant. But they did show that graded exercise therapy does improve fatigue and physical endurance. And this is very, very slow. So it's maybe a couple minutes per week increasing exercise. It's not like going from on the chair to exercising 30 minutes. So very slow progress has been shown to help. Then the other one that has some similarities is POTS, or postural orthostatic tachycardia syndrome. So for folks that are having the feeling of like tachycardia and their heart beating out of their chest, especially with exercise. So which I realize, yes. So there was a study that looked to show that cardiovascular exercise programs did significantly decrease patients' symptoms and decreased the number of patients with heart rates that actually met criteria for POTS. So essentially cured patients by doing cardiovascular exercise. I know our UW pediatric colleagues that work with POTS have a great forum online that kind of talks about things to do as far as exercise. And they do recommend recumbent exercise as a way that people feel that it's better tolerated. So doing things like a recumbent bike is better tolerated than walking on a treadmill or walking your dog for our patient here. So again, I do want to say that very slow increase in exercise is probably what's going to help these patients the most, just based on what we already know about other diseases. And then also something that can be helpful is doing things like activity logs, meaning that you plan out your day so that you don't overdo things one day and then aren't able to function on other subsequent days. Doing activity logs and talking to the important people in your life to make sure that they are aware of how much doing too much activity can affect you, and then slowly increasing to help get you back to where you used to be. So then we looked into different systems of healing. So this was supposed to include ayurvedic medicine and naturopathy and TCM and just kind of all kinds of different things. But again, very limited information that we found. So there was a couple studies on naturopathy, which are doctors of naturopathy that are trained in this. So this one was a retrospective chart review from patients at one clinic in Portland during the time of March 2020 to February 2021. Most of them were female, most of them were white. And then they, given the fact that this is kind of just their system of healing, they kind of do very personalized medicine for each person. So the things that were included were things like herbal products, vitamins, dietary recommendations like bone broth, beetroot, and greens. And then they also did IV treatments as well. It's very interesting. This study, they did the IV treatments in people's cars in their parking lot. I think it was to help decrease the, because they did some of this when people had acute COVID. But it just, I can't imagine doing an IV for someone in a parking lot. That just seems like a lot. So again, this wasn't the same treatment for everyone. It was very different for each person. But the things that they measured were fatigue, myalgias, cough, dyspnea, and loss of taste of smell. About 10% of patients had symptoms that lasted at least 1 month, which is not quite what the definition of long COVID is. It has to last at least 2 months after completion of COVID. So I circled even up to this one, but it's kind of in a gray area because of just we didn't have a definition of long COVID, so it was hard to make categories before we actually had that definition. So it is interesting, though, that the total symptom duration lasted about that long, and that's within that 5 to 80% of people that get long COVID. So it's hard to say whether or not this is actually an improvement or if this is just what the frequency of long COVID is despite these treatments, because again, we don't know what the actual frequency of long COVID is. So hard to interpret this data. Then they did another study that looked at yoga and also this same style of care. This one was not long COVID. So this were people that were treated for acute COVID only, and it was actually done in the hospital. But I thought that this was interesting because we know that yoga helps with anxiety and depression. And they were able to show that in people who are diagnosed with COVID-19, doing yoga and getting cared by these practitioners does decrease their symptoms of anxiety and depression, which is helpful adjunct for treatment. They did exclude those on oxygen, which I guess makes sense because it would be kind of hard to do downward dog with nasal cannula in, but it's not impossible. And then they also excluded people who had obesity, hypertension, and diabetes. That I thought was interesting, especially since those are people that are at higher risk of having. So anybody who has comorbidities would be at higher risk of having long COVID. So just interesting that they did not include those patients. There were no studies that were found about Ayurvedic medicine. However, there was one study that just looked at what people used in India during October 2020 and then April 2021. So essentially, they sent out a whole bunch of questionnaires to folks just saying, hey, what were you using for herbs during the big flares of COVID that they had in their country. And they didn't look at whether or not these people had COVID, whether they had symptoms or anything like that. It was just whether or not they used different herbal medications or just different herbs. Most of them are food herbs. So interestingly, Dalchini, which correct me if I'm wrong, but I think that's cinnamon, was used very frequently, and then ginger and clove were probably the top two other ones. But for some reason, ginger actually decreased quite a bit between the first wave and the second wave, which is just an interesting thing. But again, we don't know whether that's related to symptoms or anything. But just thought I'd bring it up so that I have things to talk about. And then our next was traditional Chinese medicine. Really exciting about this one is that there were a few study protocols. I kind of used traditional Chinese medicine to do a whole conglomeration of things. So there's a Qigong study that is that the protocol has been released, but they haven't actually gotten any data, again, because this is very new. And then there was another on auricular acupuncture that is out there, but again, hasn't actually been done yet. So lots of good things coming down the road, but just no data yet. So this picture here is actually from the clinic that did the one study that I was able to find. So it was done at a Seattle-based Chinese medicine clinic who specializes in all things Chinese medicine. They do acupuncture, they do herbals. And they recruited patients for this study that had COVID. It was an observational study, and they excluded patients that were on anticoagulation, anti-seizure medications, immunosuppressants, and antipsychotic medications. This was done in early March 2020, before patients were allowed, or with COVID, were really allowed in clinic. So really it focused on herbs, lifestyle advice, and then frequent telemedicine check-ins. So these patients weren't actually seen in person, which is why they weren't able to do things like acupuncture, but they were at least checked in actually quite frequently on the day of diagnosis, and then it was like 2 days afterwards, 1 week afterwards, 2 weeks afterwards, and then again at 30 days. So it was pretty frequent check-ins, which seemed really nice and to support the patients. They talked about the frequency of symptoms. So fatigue, shortness of breath, sore throat, body aches, and fevers were probably the most frequent symptoms, though not necessarily in that order. They did not specify how long they did the treatments for like the herbal medications, whether they used them just for that acute period, whether they used them for significantly longer. But they did say that of the 8 patients that did not there were 49 patients of 57 that did show symptom reduction to say that they could stop all treatments. So of the 8 people that did not finish the intervention, 3 of them were still getting treatment. One was referred to acupuncture when they were actually able to do in-person visits to try to help supplement things. One was lost to follow-up, and then one developed cancer, so was taken out of the study. And then 2 patients just chose to stop therapy on their own, not necessarily because their symptoms reduced. So interesting, and lots of good things coming down the road, at least for traditional Chinese medicine. Hopefully in the next couple of years, we'll have a little bit more information here. And then we move on to mind-body therapies. So again, there wasn't a lot of data. I just feel like a broken record when I'm saying that over and over again. But essentially, there was a study that showed that psychoeducation, relaxation exercises, and activity scheduling, so things like planning to have recreational, physical, social activities each day, does reduce post-COVID anxiety. So they had 30 patients who previously had been diagnosed with COVID and scored low on an 18-item mental health inventory. They didn't actually say what low meant. It just was low. So I'm not entirely sure there. But they also excluded people who had comorbid psychiatric disorders, vision impairment, hearing impairment, any organic pathology, anxiety disorder, substance abuse, or intellectual disorders. They were treated for 1 month with 30-minute, twice-a-week sessions that kind of used the psychoeducation, relaxation, and activity scheduling. And then they were re-evaluated after 1 month. So again, not really long COVID, but at least we can show that these things help decrease anxiety after COVID. It was a very poorly written study, and this is kind of a weird graph. There was no... I'm not entirely sure what this means. I think it's probably the score on the MHI. Also, it's odd that the standard deviation is just here. I don't know. It was a weirdly written article, but psychoeducation, relaxation, activity, we know those things decrease anxiety. It's helpful to say, okay, it also helps when someone has had COVID too. Other thoughts, so mindfulness helps to decrease the level of anxiety during the COVID pandemic. There was a study that looked at that. However, it wasn't long COVID because it was just looking at people that didn't necessarily have COVID, but were just more anxious, because a lot of people were more anxious during, especially those initial months of COVID. And so we know mindfulness helps that. And if people are anxious with long COVID, it's probably going to help. But we just don't have actual data to show that. And then the other thing that I wanted to mention was that PACE trial that I talked about earlier for chronic fatigue syndrome did show that CBT was helpful. That's behavioral therapy was helpful in decreasing patient symptoms. I realized, yeah, I should have written that out. Okay, so that brings us to our conclusion. So essentially, we know symptoms can last past 12 months after the diagnosis of COVID, but we're not really sure how long to expect it to last. Is this forever? Is this something that will eventually stop 5 years down the road? Who knows? The development of long COVID does not necessarily correlate with severity of infection. And there's just a lack of overall data on treatment of long COVID that hopefully will improve over the next couple years. So things that need future study, I'll just mention the ones that I talked about. So nutrition, we need more best practices for dietary guidance in these patients. We need to evaluate ways to identify those who are at risk and how to support them after the diagnosis. For body work, we need to, again, determine best practices for activity recommendations since there's not really much data there. And then also determine if anything else will be helpful. Would manipulation be helpful? Would healing touch be helpful? Would massage be helpful? Probably, but we just don't have data on those things. So that's why they weren't mentioned. And then jumping down to systems of healing, I don't know why we put that in this order, but systems of healing, it would be nice to hear more about other ways of treating people and whether or not those are helpful. And then mind body, I would love to see a study about mindfulness-based stress reduction for long COVID for those who do that sort of thing. So yeah, and then Anya for supplements.
Yeah, jumping back up to supplements, obviously a lot of the studies had quite a low power. They were also done in the acute phase, so not really in that beyond 3 months phase that we describe as long COVID, but we don't really know if supplementation early on in the disease or acutely after the disease, if that prevents maybe symptoms from continuing beyond 3 months into an actual diagnosable long COVID. Also not included in here is, or I guess studying if how the vitamin supplements work in tandem, which we saw a lot of those multivitamin concoctions together. And I'm personally interested in further studies, I guess, on the microbiome in long COVID, since the strongest studies that we had listed in the review were on probiotics, and maybe supporting the microbiome through probiotics would, and even the possibly digestive enzymes, since one of the studies did include digestive enzymes, maybe there is some value in supporting the body through the microbiome for long COVID, or even for those who are at risk for developing long COVID. So those would be some interesting future studies.
So what can we do for our patient that we talked about at the beginning? So if we remember, she's our 51-year-old healthy patient who has been having debilitating fatigue that has been preventing her from walking her dog. So for everybody, eating a varied, healthy diet that is high in fruits and vegetables is probably going to be helpful. And then as far as exercise, doing graded exercise therapy that is potentially recumbent to exercise in order to help would be helpful. Doing activity logs, doing therapy could be helpful as well. And then considering other methods such as acupuncture, mindfulness-based stress reduction, traditional Chinese medicine, potentially healing touch, ayurvedic medicine, anything, because we just don't have data. But if it's helping someone and they do find that it's working, I think that it's worth to try. Yeah.
Yeah, and for supplements, we did see that with most of the studies, there was improvement in symptoms of fatigue. Interesting enough, most were appreciated within a month of therapy. So most of the supplements were given either for 2 weeks or even up to 30 days. So one approach could be, when considering supplementation for patients, we can suggest a 1-month trial before completely dismissing the efficacy for fatigue symptoms.
And lastly, I just wanted to mention this wonderful resource that I found while going through all of these articles. So in Great Britain, they went and created a really amazing process for supporting people with long COVID, in that they have this website to kind of support everyone. And like patients, general practitioners, it allows people to just be able to kind of look for the information themselves. But then they also created a team of people who are specifically working on this for people that are struggling a lot more, patients that are struggling a lot more. And it includes an occupational therapist, a physical therapist, a general practitioner, and then they are able to kind of reach out to any other specialties that they would need along the way. But I just for getting general information about long COVID and supporting patients' recovery afterwards, I thought this was an amazing resource. So I wanted to share that with all of you today. And then we have all of our references, all 198. So that was about it.
Thank you. I think Vinny had to run off, but I know we're cutting it close to 12, and we'll just definitely, we want to respect everyone's time in doing whatever responsibilities they have next. But what questions came up? If anyone has any questions, we'll take one or two so that we can get everyone out by 12.
Thanks, Anya. I'm here, and I thank you
Okay.
for, yeah,
I
I just
didn't
had
realize you were
one.
still there.
No, it's okay. I'm gonna head out here in a minute to pick up my daughter from school. But I did want to just thank you both for this incredible work that you have done. I'm so impressed, the thoroughness of the systematic review, like really thinking critically about each of the like articles, what you include, what you don't include, how to appraise them critically, and then how do you apply it in real life. I think it's obvious to me that there's obviously pretty much everybody probably, there's a lot more work to be done here. And it's really wonderful to have this sort of pin in the map of like, all right, this is where we're at right now. Where do we go from here? And you know, for me, I'm always thinking about, as we review these studies, thinking about what are the biases in the researchers, and you know, looking at some of the brands of like the vitamins and different things, like what are the biases that come into some of these studies, and also like the applicability of these studies to all populations, right? Recognizing that sometimes the supplements or different things that will be that have been researched might not be practical or affordable to all populations that we serve. And so, yeah, I again just so grateful for all the work you have done. Thank you all. Please enjoy a few more minutes with each other. And I think in May we'll be doing a kind of informal gathering just to check in with each other before we break for the summer. So thank you all.
I did want to quickly address one of the questions that was put in there. Was the initial patient evaluated for arrhythmias or cardiomyopathy? Yes, they did have a Holter monitor that did not show anything. Sorry, I forgot to put that in there. And so then the next step was to do a stress test, which we were in the process of getting. And then the other question was any testing of the GI microbiome done on the long COVID patients prior to initiation of probiotic therapy? Not that I'm aware of, because most of them were, sorry, I guess I'll let Anya answer that one.
No, yeah, either way. I mean, they were not done, no. And I think one exclusion criteria for one of the studies was that they couldn't be on another probiotic during the probiotic study, which seems almost obvious, but there was no testing, any mapping of any sorts before the initiation.
And also, thank you for the info on POTS as well. We were trying to focus more on the integrative approaches, which is why we didn't focus on things like that. But yes, that is a very good point too. So thank you for bringing that up. And then also thank you to the the mention of OMT, and I'm really looking forward to hearing about that study when it's completed. That's really exciting.
Yes, Jed, thank you so much. I am also very excited about that study and what will be found, and all those interesting exam findings that you see in long COVID patients. That's really fascinating.
Yeah, you guys aren't going to have the hand skills to be able to pick it up, unfortunately. But yeah, it was pretty surprising that there were so many, especially pericardial pleural adhesions. And for me, it's biologically plausible that that would explain a lot of symptoms. And that if you have inflammation of the serosa, you basically can get surfaces which stick to one another. And so by freeing those things up, that'll, take a lot of energetic burden out of the body. So we'll wait and see.
Yeah. Yeah, really exciting research. And then one other question that I see in terms of female gender being a risk factor for long COVID, are there theories around who is presenting for care or otherwise identifying themselves as people who have long COVID? That's a really good point because women tend to go to the doctor more and present a little bit more frequently for symptoms like this. I don't know of any theories around that I found while we were looking through that. Any other questions? All right. Well, it was really wonderful spending the morning with all of you and sharing the information that we found. And hopefully some of it will be enlightening and some will just be more exciting things to learn in the future, since there's a lot of things that we don't quite know yet, but at least we're headed in the right direction, I think. So.
Thank you.
All right.